Okay, we've started recording, and this is Dr. Bill Waytt, and I'm gonna record a deal on Class 3 non-surgical correction. And we've got a couple of cases like this I'd like to show. I want to get my little marking pen up here. Okay, the recording is on the way, and it's early in the morning, and I'm down here working on this case. These cases are treated by removing both lower 6-year molars. The lower third molar must be present to attempt this. Now, we've done some pretty bad Class 3 cases simply by removing the lower 6-year molars and bringing the lower anterior teeth back to Class 1 and the lower second and third molar up to Class 1 position. So we'll go through this case, and I'll show you what I think is something we should be doing. This young lady came in, and you can look at her face. There's no question about her being Class 3. She's got a very prominent lower mandible, and just looks like it's a little deficient right in the upper part of the facial structure. At the base of the nose needs to be filled out a little more. So we'll look at this after we get through. Now, I've known this lady for years. In fact, she's still she was in Glenrose and I was in Hearst, and we moved to Glenrose, and she recognized my name, or my wife, and asked her about it, and so we found her after years. So we've started this case in looks like February of 1987. So now we look at the face from the frontal view. Let me go back and erase that now. From the frontal view, and you still see this deficiency right in this part of the face, and this is prominent in this area. So it's a definite Class 3 case. Now when she smiles or opens her mouth there to where you can see the teeth, you can get a better idea of the Class 3 problem. Now, if we look straight at the molds, the upper centrals are fitting behind the lower centrals, and these are crowded up. If you straighten these out, it would even be more out to the front than it is now. And if the thing we're going to do is just common sense to me. We'll come back here and take out these 6-year molars, and then we're going to bring these teeth back to a Class 1 relationship, and we'll be pulling them back by pulling off of the upper in this direction. We'll also be pulling them back because this tooth will be gone. We'll be dragging these teeth forward, and the force to bring them forward, we bring this back too, and then we can substitute Class 3 elastics in the case to make sure we come out on the Class 1 side. Now, these teeth are kind of torqued back from the lip pressure, so if we torque them forward, it's going to make these teeth look even worse, and we want to bring them back in a proper torque relation. So you've got to bring the root structure of these teeth back, and this is a pretty difficult thing to do. And we like to bring these teeth forward, and we like to move their roots forward too, so we keep them torqued properly. and so you're actually going to kind of move a point out up above. So it's a pretty, the thing that happens is pretty complicated, but to do these cases is not all that difficult. So I don't want you to be afraid of trying to do this. Now we're going to take out these teeth right here, and we're going to move this tooth up to a class 1 relation. It'll be something like that in relation to this upper 6-year molar. And we'll bring these teeth backward, and we'll take this bicuspid and put it right in this area here. Then the next one would fall into there, and then our cuspid would come in this fashion up in here somewhere, and these teeth would be under. We'd expand and straighten these out. We'd straighten these out, and you have an overjet and overbite would be pretty normal when you get through with the case. So we'll show these models when we get to the show, so you can compare what's going on here. And we're going to do virtually the same thing over on the other side. Now when you get through, this tooth won't have anything to come against, so you can just leave it there. It's not going to ruin things if it's there. So we'll go on to the upper models. As we come forward with this maxilla, we need to widen it out. So we're going to use a large, what we call our Big Daddy arch wire. We'll have it out something like this and bring these teeth out to meet it. We'll also have to kind of get this one to come out with it in that area. Excuse me, let me go back to that picture again. So we're going to expand the upper arch in doing this. Now this is an 040 wire we put in here, what we call a Big Daddy arch, and you can expand almost anything that's alive with it if you want to. Now to bring it out, you have to put buccal root torque in it, or you're just going to lean this crown out, you see. So you put buccal root torque back here in these teeth. That brings the roots of the teeth out as well as the crowns of the teeth. So you need some of that in these up here. You may even have to band the upper molars, but I don't think we did to get the buccal root torque in the upper second molars. So let's watch what we're doing here. Now on the bottom, we've got an interesting situation. You've got a tooth that's almost 90 degrees rotated. It's really not. It's about something like that. But whenever you have a extremely rotated lower anterior tooth, you can figure on having to strip the gingival tissue, and also some of the bone structure will be stripped off of this root when you rotate it. There's not much way to do that. You could, if you could get a bracket on the edge of this tooth and torque this root back in, you might could avoid that, but we didn't go to that extreme to do that now. And of course we're going to extract these 6-year molars. We're going to bring this back about here and bring this forward up to about there, something like that on both sides. Now when we look at it cephalometrically, you can see, get a good view of the condyle. You see where it's up in here, and the pagonian, the bony structure here, is out front. Now we're going to bring these lower anterior teeth back, and I want to have them, the roots brought back too. And when we get through with this, you're going to notice that we did not move the chin button, but we moved the teeth on the jawbone, and it moved back about that far. So we'll look at pagonian when we get through, and you'll see that it's something like that. But it's not, doesn't withdraw, doesn't mess up this young lady's looks. If it did, it would be a simple matter to do a genioplasty. I say simple, but it can be done in a or surgeon's office and drop this thing back, and put it back in here. But when we get through, this looks quite normal. So just remember that when we finish up the case here. Alright, here we've started this already and we're going. Now I want to point out that you always wait to extract the teeth until you have the brackets and everything on and you're ready to move, so that the day you take the teeth out, you start moving this back and this forward in here. Now if you come out a little to class 2 or class 3 as you're going, you can see what's happening. Then you can use class 2 elastics, or you can come in here with class 3 elastics, whichever one is necessary, so that you end up with a class 1 relationship between the teeth. That's just common sense, but I hope that you realize you can do that as you go through the case. Now this young lady had complications that you don't find in a lot of cases. She had periodontal problems around the teeth, and so we're moving periodontally involved teeth up here, and that's a shaky business. Now I asked this young lady if she smoked. If she hadn't been a smoker, I would have been very reluctant to go in and do this case, because it makes the periodontal situation worse. But she wasn't, and so we went ahead and started it, even though she had bone loss. And you can look at the bone loss where it was when we started and where it is after we finished, and I can't tell that there's much difference in it. In fact, I just saw this lady last Sunday at church, and she's still got a beautiful set of teeth, and that's from 1987 when we started this. We finished it about a couple of years later, be about 89, something in that area. And here it is, 2014, or it's getting pretty close to that. So this has been done for a long time, see. So, and it's still stable. She's still working with it. I've got some pictures of her up a few years ago. I haven't got some update pictures on her yet. Now, here it is after we finished. Now you remember where the begonias stick it out, and here now the teeth are like that. Let's go back, and I'm going to show you where it was. If you think this can't happen, it darn sure does, you see. Now the point of the chin stayed where it was, but these went back, and these teeth are lined up somewhere back in here. Now, I'm going to go back again, and you look at, jumped too many. You see where the bone structure is at this point. Now this begonia did not move, but the alveolar bone that supports the teeth did go back, move back, but it still didn't make her look bad. So I didn't recommend any genioplasty here, but you could have if their chin structure was sticking out too far, and it was a aesthetic thing. But she knew that she could do this. Now this picture right here was taken in 2010, right here, so that's 87 to 97, 97 to 2007, and then 2010, that's of 23 years, and now it's another 3 or 4 years onto that, so it's been done quite a long time, and it's still quite stable. Now the bone structure at this point is just about as good as it was back when we first started the case. You see the bone structure here around the 6-year molars. That's the second molar. And now you look at it at this point, it's almost the same. Now, she's still got some periodontal problems, but she takes care of her teeth quite well nowadays. Now, here you could see and this is, I mean, you got to kind of wonder if I'm going to drag these teeth all the way up to here, you see, and pull this tooth out and be coming something like that. So these roots of these teeth have to come forward quite a ways in there to accomplish that. Now, if this is a smoker, you're going to have some problems with it. And we thought we were having problems. We slowed down and went slower. And she's got periodontal pockets up above too. In fact, they have periodontal situation in the family. So she's got the genetic defect there that makes periodontal problems pretty prevalent in that family. So they have to really watch their teeth, watch their bone structure as they go along. She's taking care of it real well now. Okay, we extract the teeth, and now we start immediately. We've already moved that tooth forward. It's kind of tilting over here. We want to bring these roots up. Now, as you go, it'll look like you've got more pockets and deeper pockets, and because the attachment really hasn't been broken, you will drag this forward and it'll look like you have more bone loss. If you just sit there a while, the bone fills back in as long as you didn't destroy the attachment up at the top as you go forward with it. Now, so here we are along the way, and the bone looks better in this picture. This is January of 88 right here. And let's see, the picture here was, well, I've got the date gone here, but it looks like she was 25 and 5 months at this point. The bone looks worse here than it does after we go to this point. Now, we stopped in there and rested the case for a while, and I told them it's a possibility you lose the teeth, but she wanted to go ahead anyway. She had been to 2 places, and they wanted to do surgery on her to correct the class 3 problem. So we've done this without any surgery, or jaw surgery at all. So here we go. Now this is 5 of 88. We're up at there. The bone structure looks much better around here, but as we drag this forward, you'll see a widening of the periodontal membrane and everything. But the bone will fill back in after you get into place. Here's an 88. We're coming forward with it. Now that's number 7, and I can't see the date on that real good, but we've got the crown almost everywhere. We've got to bring these roots up to here. See, so that's going to be, and where we take an arch wire like here, this arch wire would be going down this way as we pull on it, so that keep these roots coming forward as we do this. This is touching over here, and these roots have come forward quite a bit. Now these have gone back to some extent too. So we're correcting the class 3 problem as we go along. Alright, at this point, we've got the roots pretty well paralleled, and it looks like we've got pockets all in here. But wait until we leave this alone for a while and hold it there, then bone fills back in around these areas to some extent. Now it looks pretty bad over here too, but this bone will fill in back in there. Now our upper 3rd molars are just going to be kind of left hanging in the breeze. Okay, here we are clinically doing this, and we started out with a little wildcat wire. Just you can use an 016 or an 1/4 tie wire if you want to, and you can put some expansion loops in it. Now this wire, it goes back and it's longer. It'll be setting out in front of the teeth when you go to wire it in, and this loop will be open like that, and as it pushes this out, you'll have your loop will be kind of back like that, so the wire's pushing on this all the time to expand it up above with that upper arch wire. Now down below we'll have to get some expansion too, so we'd have loops that are open, and when we get them tied back in there, this loop will be closed. So it's trying to open this space, and it gradually does. And as we get space here, we're going to start turning this tooth around, and you're going to have some stripping on that. It just will almost invariably happen. So and the problem for something like that is that the anatomy of a lower anterior tooth is kind of odd to look at. I'm going to just draw one off, like if you have a lower anterior tooth. This will be pretty flat on this side, and then it's rounded off as it comes up here. Now if you look at the tooth just from the front part, it's wide here, and then it tapers off, and it's pretty narrow down like that. So when you turn it sideways and you have this thin part of the tooth to the labial, the bone will be right in here, and so when you start to turn it, this will just actually go through the bone structure, a lot of area like that. Now if you could come back in, say, and it's kind of a funny shaped bone in here. If you could torque this tooth and bring this root in and then turn it, but it'd be very difficult to put a bracket on but I guess someday we'll do that and bring that in, and then you can turn it where it would be in the bone structure. Now watch this as we go through. It strips down and then the gum comes back, but we have lost the attachment on that. So as we rotate, this is just something you need to know. If you get somebody with a lower anterior tooth that's nearly 90 degrees rotated, you're going to darn near always strip through the tissue and some of the bone in doing the case, or just tell them to start with. That doesn't mean you'll lose a tooth. Alright, we make space in here. We're pushing apart and opening this out to have a loop here that's condensed now, so the wire's pushing out, and then we've got spring in here is pushing it apart in this manner right here. And up here this loop is condensed, so the whole thing is pushing. We're trying to widen the upper teeth out also. Now the cuspid will need to be tipped and rotated, which is an obvious thing you do in any kind of orthodontic situation. Alright, we are going to line this up, and then we're going to expand this upper arch to get this where, as we advance the lower mandible a little bit, as we get out from here and advance it, it'll be a wider area come in to fit on the occlusal surface of the upper arch. Okay, we're about ready to start rotating this tooth. You need enough space in here, to actually spin this tooth around, and we can do that by pulling back here with a chain, or actually pulling back on tooth from this side, which will tend to rotate it. You can actually take just a little chain, and you half hitch that chain onto the arch wire itself. We'll show that on rotating teeth. You bring the chain around this tooth and hook it around the bracket, And as you get space in here, that chain will be pulling on it from this side, and this tooth will just rotate around like that with that chain elastic on it. Alright, we've still got the prominence of the lower jaw, but it's looking a little better now. We've gone back some of the way, but some of the fullness is still in there, and a little deficiency in this area right here. So we're still working that way, and we haven't really finished this by a long shot. So the time we get it finished, it'll look much better than that. Now, this is 5 of 87. That's not too long after we started the case. And if I'm looking at this correctly, there's a little elastic chain tied around here, goes around this tooth, comes out over here and hooks onto the bracket, and so it's kind of spinning this tooth in this direction. It's spinning it around like that to pull it in place. Now, as we do, it's going to tend to strip right down here on us. It's already done some of that. It wasn't perfect when we started with it. Okay, we're coming forward with a molar, and we're going backward with these teeth. We can do that with that little arch wire. It started immediately. So here we've hooked the elastic chain back here, and we're closing these bicuspids back. Now we need to get in there pretty quick and get our big daddy arch wire to expand that upper arch too. Alright, here we are with the brackets on, and we've expanded the upper arch. We've got space between the teeth here and here. Probably have to move this over a little bit. This is lined up with very little space in it right now. Now we're closing with elastic chain right here. See, we're hooked this chain elastic right there. Now if you want to rotate these teeth some, you hook this on the lingual button on the, and you pop it through and then bring it down, hook it under the elastics on these two teeth, and that's pulling back here and it's pulling forward over here, and it's also rotating this tooth in this direction. As you pull it forward, it rotates that some. Alright, here's the large overlay type arch wire that we put in the upper area, and it's expanding the upper arch quite good. Alright, we've expanded out, and we had to start using some buccal root torque in those upper molars now to keep the roots going out with us. Now down below, we've come further forward over here. We got this tooth leaning, so it's really no better off than this one over here coming forward bodily. Alright, we've rotated. This is January 28th of 80, I don't know, it's 87 I think. Now that is stripped off to some extent in here. We go ahead and keep it like it is, and we'll torque this tooth in. Now we're in a rectangular wire, so we're going to put torque in to bring this root back into the bone structure on this side. Now that's coming along fairly good. Okay, we're about halfway through this. This young lady puts on a few pounds, and as you can well know, it affected her looks. Now 25 or 27 years later, I saw her just Sunday in church, and she's a stewardess on one of the airlines, and husband, and she has a son. He's a class 3 too, but they didn't bring him into our office to do. Anyway, she loses some weight, and she will look a lot better as we get down the way. Okay, we're quite a ways into the case right now, and we're doing another thing here that you need to understand. And I don't like these little composite or these clear brackets. You can't torque good enough with them. I want to put reverse torque in these upper anterior teeth to bring their root structure out so that they aren't laying out like this, they're more or less like that. And to do that, you've got to have a vascular bed go in front of the bone that's moving out, you see. So you got a pretty tight muscle up here, so we put a lip bumper in, and this lip bumper will run interference, and it'll have a little space between the back part of the lip bumper and the tissue, and you keep that space in there as you reverse torque these upper anterior teeth that bring them out that way. That's a kind of a trick. You need to know how to make those lip bumpers. They fit in that auxiliary tube, everything. Alright, she's looking real good as far as the tooth-wise situation. And we look on the side and we're nearly class 1. Now as we go back, we've got the molars almost in class 1 relationship here. See, this upper molar coming down and this one back here, so it's pretty well done. As we come along on the case, this tooth gets to look a little better. We're putting torque in there. See, we got some reverse torque, or actually it's torque that we got on these lower anteriors to bring this root in where it was coming straighter out to start with. So we're torquing it in as we go. Again, same situation. You can see how that lip bumper has got some play up here. We're going to reverse torque that. Alright, the upper arch is lined up quite good at this point, and the lower arch has got a few more months of work in it to do it. We're in 89 now, 87 to 88 and 89. We're getting close to a couple of years in treatment time here. Alright, the midline looks good here, and the torque and everything, and the tissue is looking better around this tooth. I don't know if she ever has done anything with that, grafting that or not, but it looks pretty darn good right here, and we're in a good class 1 relation now. Okay, we've still got a little space to close over on this left side, looks to me like, and everything else is lined up pretty good. Alright, she's lost some weight, and she's got a little prominence of the chin, but it's not detracting from appearance. She still looks good. So I wouldn't recommend this. This was a 91, and we're just about to finish the case, or maybe we have finished it. She's probably been out of it for some time now. She's not brushing them like we would like, but there it is in 91, and this was 87, which is about, let's see, that's about 4 years there. So she's been out of this for some time now. When we look at from the side view, you can see where we took this out, and you see this molar. I didn't get a side view with in the mouth here. It's good, so you can see it, though it's virtually class 1. From the other side, same, and we widen this arch out with that Big Daddy wire, like that to that, you see. And the lower arch is somewhat widened out down here with the cuspids and everything. It's had to enlarge that So it's bigger down there and bigger on the upper too. Alright, this is 91 and it's looking quite good. Now we'll go through it. Alright, the lady, I didn't see her for many years. And then we moved out to Glenrose and she recognized my wife and by her name. In fact, my wife had her son in her Sunday school class. And I didn't know that this was the lady I had treated either. And she came up and introduced herself, and I was thrilled to death to see that her teeth were still beautifully placed. And I had all these slides on her case to start with, and looking at the facial structure, you would find very little deficiency or the prominence of the jaw, even though the chin protrudes out just a little bit more than you would really want it if you were doing it in an ideal situation. And the teeth look gorgeous, you know. It's been from 87 to 2010, and so it's about 20-something years, 23 years, I think, something like that. And that's darn good, you know. And she didn't have to go through jaw surgery or anything, and it's very stable. And I've done this on a lot of people, and it works. Now she brushes the heck out of them because we did this, didn't cause this recession of the gum tissue. She needs to take care of them a little better than she's doing right here. That tooth that was stripped, the tissue looks just about as good on it as it does on the other teeth around here. Now that was 10 years in 2010, and I saw her just the other day, and so we stick another 3 or 4 years on this and they still look good. And that's a good class 1 relation. Back in the back, same thing over here, overjet, overbite, and the torque on these teeth. So we brought these teeth back in. We didn't leave them tilted like that. Brought them back in, brought the roots of the teeth back in. She's had a lot of fillings in the teeth since the time we took these before, but everything's looking good. Down on the bottom, so here's where we started, and there's where we are in 2010. Here's starting on the right side of the mouth, and there's the second molar coming up. The wisdom tooth kind of still in there, just popped down on the side of that. She could get them out if she needed to. Alright, here is the Panorex in 2010, and the bone structure is not too plain on that, but you can see the bone looks as good now as it did when we first started the case, even though she's got this periodontal defect. The upper wisdom teeth are coming in. They may grow in and hit the tissue down there and you'd have to remove them, but this is a good class 1 relationship. Still got a little space right here that hadn't closed up. And here's the models that we took, and it doesn't look as if it's perfect class 1 here. The midline's off just slightly. It's more of a class 1 on this side. That's 2010, which is 23 years from the time we finished the case, and now we've had another 3 or 4 years on this, and you've got somebody that's been out over 25 years, you see, this treatment. So it went from 87, and there's 88, and there's 2010. And see, this begonian is sticking out here, but it doesn't detract from her appearance. It seems like the mouth fills in around that area. Now if you go back and look at the begonian to start with in 87, and now look at it, that's 88, it was back like that, now it's here. So the point is, the chin button is protruding out, the teeth move back in kind of a bodily movement of the teeth. Okay. Alright, this is case number 2, and I'm going to stop right here, and we'll come back and finish that. I'm going to push F